Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of an elderly female who presented to ER with complaints of fever, breathing difficulty, and productive cough since about 10 days. Can we begin, sir?
Yeah.
So there was this elderly female who was brought to our ER with complaints of 10-day history of intermittent but high-grade fever. Along with this, she also had insidious onset and progressively worsening breathing difficulty and productive cough. So in our initial 10-second assessment, she was conscious, oriented, and obeying to our commands. So moving on to the primary survey, airway-wise, airway was patent. There was no increased secretions, no pooling of saliva, no hoarseness of voice that was noted, and no stridor also noted. Breathing wise, she had air entry to be bilaterally equal. She was tachypnic with respiratory rate of 36 beats per cycles per minute. Maintaining saturation, she came on oxygen supplementation of 5 liters of oxygen. On this, she had a saturation of 92% on oxygen supplement. And then moving on to circulation wise, she was
Okay,
hypotensive.
we'll just wait there. So now we have a patient with a suspected infection coming with tachypnea, right, on presentation. What are the causes you will think about when the patient is severely tachypnic and sepsis? What could be the focus of infections?
Foci of infections could be one, lung could be the foci of infections, because lower respiratory tract infection or any upper respiratory tract infection with when the patient is anxious can cause tachypnea. Urinary tract infection, pyelonephritis, and septicemia basically can cause tachypnea.
Exactly. So never restrict the focus to lungs. It will be part of your other mods itself. Okay.
So
So
circulation.
renal failure, again, patient will be tachypnic. Primary neurological issues, that itself can present with tachypnea. Okay.
ARDS.
Yeah, it need not be a lung finding, need not always be there. Okay, continue.
So circulation wise, her peripheries were
What
cold.
was the respiratory system findings?
Air entry to be bilaterally equal, and auscultation wise, she had crepitations.
Where was the crepitation?
Precisely all over the lung field, sir, but majorly on the left infrascapular and axillary area.
Okay, bilateral crepitation.
Bilateral creps.
Right side it was more.
Yeah.
That is bilateral. So okay.
So circulation wise, all her peripheries were cold. She was hypotensive with a BP of 80/60 and was brought on inotropic support of NORAD, going on at 8 ml per hour. And then all peripheral
So basically,
pulses.
it is referred from another hospital to
That's
us.
right, sir.
Okay.
All peripheral pulses, despite being palpable, were feeble to feel. And
Just wait there. How many days she was in another hospital?
for about 5 days.
Why is that data important?
For hospital-acquired infection.
So how will you define hospital-acquired infection?
For 24 to 48 hours before, after
48 hours.
48 hours after the hospital admission.
New onset
admission,
fever or signs of infection
which
post 48 hours
which she
after an
previously did
admission?
not have.
Okay.
Here this patient already had fever.
Had
cough.
fever,
So that's why she went to the hospital.
Hospital, sir. She was initially the first 2-3 days she was treated on an OPD basis, but when the symptoms improved and her symptoms persisted and worsened, and patient overall condition deteriorated, is when she was hospitalized.
What is her age?
65 years, sir.
65. So she should be admitted or discharged when the
Admitted.
initial presentation itself. What was
Going
your
by
opinion?
CURB 65, she should be admitted, sir.
What will be the criteria?
CURB 65 is a very simple tool that we use. C is for confusion. Urea has to be more than 7 millimole per liter. Respiratory rate of more than 30 cycles per minute. CUR. B is for what? Blood pressure less than hypotensive, less systolic BP to be less than 90, and 65 to be the age.
Okay. So
So-
what is the criteria for admission?
More than 2 is ward admission. More than 3 would be ICU admission.
ICU admission. So maybe we don't know what was the presentation initially, but only one score we can definitely say 65 years of age. So with this fever, she should have been admitted. If there was anything else, what was supporting to curb 65? It's a simple thing. So one major important thing what you have to consider is any elderly patient that is above 60 that is coming to the emergency, ideally they need to be admitted. That's the one thing. When we just analyze the data of all geriatric population coming to the ED with whatever be the issue, either with fever or any outer sensorium, in general dictum 80% of them need admission. Okay, so what was the initial antibiotic that she was given?
She was there itself on meropenem, sir.
No, on the initial OPD basis, any idea? Any idea that which drug she was taking?
She was initially on azithromycin on an OPD basis, her first medication.
Okay, on OPD basis, she was started on azithromycin. So you think azithromycin is an ideal agent for this patient when she visited the OPD? You just presume. I am not saying anything else. You think azithromycin is a good agent? You can start this as an OPD basis.
So first, it would be a community-acquired pneumonia. For community-acquired pneumonia, our major organisms that we will be targeting is gram-positive, like Streptococcus and Staphylococcus, for which azithromycin would not be an added coverage. Like we would prefer a penicillin group of drugs. But
a combination of macrolide.
yeah, with a
azithromycin is a very good OPD based drug. It is a very good drug that can be given. It has got very good gram positive coverage and atypical coverage, which is very commonly that we are seeing. You don't have a gram negative coverage. It's a basic dictum. If the patient was a diabetic or an alcoholic or any other immunosuppression, that would have not been ideal choice. But otherwise, it would have been ideal choice to start with azithromycin. There is no harm in giving azithromycin. So options will be, first will be your azithromycin or macrolides. That will be the first line. Then you have respiratory quinolones. You have always have levofloxacin, moxifloxacin, everything. So that will be the next option in line, which have got very good gram positive, gram negative, atypical coverage. That is the other thing that you can start on. Then even doxycycline can be started as an oral therapy initially. So these three agents are definitely you can start. The first line of agents, if the patient was going there, no comorbidities, no diabetes or anything, azithromycin would have been a reasonable choice to start with. But if she had any other findings, any other comorbidities, then it might not be a good agent. But community acquired pneumonia, initially to start with the OPD basis, azithromycin is recommended.
Okay. Then
so coming to the hypotension, you said the patient was cold, clammy extremities. So what do you expect in a shock?
Depends on what kind of a shock we are
So
dealing with.
what do you expect for this patient?
This patient, it's a septic shock, so we'll be expecting more on the lines of warm shock.
Okay.
So the patient will have warm extremities rather than cold clammy.
So you said it's cold extremities.
But she had long-standing, plus she had a heart.
Maybe secondary to the anatomy was going because of
vasoconstriction.
Okay.
Maybe.
So she was already receiving noradrenaline, but still her BP has not improved, no?
No.
So still her BP is not improved. It's already
So
80-60, you are giving 10 ml per hour noradrenaline, BP is not improved. So what could be the other?
One possibility is either the medication wouldn't have been going properly because the transportation, she could have had that, or she will probably she's in a shock state wherein she needs another inotrope.
So you mean to be refractory? That's what you.
Refractory we cannot say unless two inotropes have failed.
One inotrope itself is enough. Refractory. To call it refractory, one inotrope is enough. When you want to start a steroid, the first thing that you have to say is refractory shock. That is, one inotrope is not able to maintain the blood pressure, you can start steroid. So she's in a refractory shock, or otherwise there is an additional cardiogenic shock. Cardiogenic shock. That will be the other reason. So classical cold peripheries when the patient presenting will be in either in cardiogenic shock or in hypovolemic shock. That's what classically seen. But usually in septic shock, what is the dictum? What we see usually is a warm shock. We'll be able to see peripheral pulses. But always remember, it will be a combination. It will not be like septic shock alone. It will be a combination of septic shock, and this sepsis can cause myocardial dysfunction again. So it will be a combination. Underlying CAD patient is there, so underlying worsening of the LV. So it will be a combination of both. So we have to tackle both. That's the important message that we want to give. And maybe volume replacement may not be having adequate. So volume replacement, they have just started noradrenaline. Just seeing the hypotension without giving adequate fluid, they would have just started noradrenaline. So all those things you need to have a comment when the patient is having hypotension. So what will be a target blood pressure in this patient?
So our mean arterial pressure would be the ideal one, which will target as 65 mmHg or above.
Okay. So first of all, you're seeing a BP of 80/60. You're not happy. So how will you treat this patient's hypotension? This patient.
Sir, as we see more of the case, we'll realize that this patient also has a cardiac component along with
Initial steps. So you have a patient with hypotension already on a single support. How will you assess and then which path are you going to follow?
First, if the patient is fluid depleted, we'll just have a quick contamination with the IVC and all that. And if she requires more fluid, we'll try giving a fluid challenge. And we'll see if the patient is improving or not.
First of all, most important thing, what is the line the patient is getting in? she's getting proper peripheral line, how the infusion is going on. That's the first thing that you need to have. When you're giving a high dose of noradrenaline, whether that line is enough, the drug is going in. We wanted 2 peripheral lines, basic things you have to start with. Then if not, you have to assess, as you said, IVC. That is one baseline thing that you can do, but you can still do certain other things. You can look for any evidence of pedal edema. Already there is an underlying cardiac failure. So this all will give you a clue what could be the fluid status of the patient. Then
So,
suppose the IVC is, I am telling, it is collapsible.
so if IVC is collapsible, then we can give a fluid bolus of about 250 to 500 ml fluid challenge we can give and look
What does the surveying sepsis campaign guideline say? What's the initial fluid bolus?
30 ml per kg
of
within
what?
3 hours of resuscitation.
Select upon 30 ml per kg of fluid and we give over a period of like 3 hours or so.
What? Of what?
Isotonic
This thing,
plasma light.
So there is definitive recommendation to go for a balanced crystalloid over
Like
colloids
plasma
or
light is preferred over
Plasma
NS or
light,
And we can consider as a balanced one.
NS or
is
other
giving
colloids.
oral contraindicated in lactic acidosis?
It's not contraindicated. The earlier notion was that patient had RL had lactate, so it will increase, but it doesn't increase.
So 30 ml per kg. Okay. Then
Within 3 hours of resuscitation of a balanced solution, and then then when we see whether the patient is fluid responsive or not, and rather than a static or patient's hemodynamic status, we'll have to look for dynamic parameters to judge for fluid
What are the dynamic
status.
parameters?
One would be the IVC, urine output, and the lactate clearance. So
What is
these would
passive
be
leg
the-
racing test?
in passive leg racing test, we it's basically
we keep the patient in supine position and connect to all hemodynamic monitors, especially if we have available cardiac output monitoring, if possibly we have available. And we
So that is not being done usually. No? What can act as a surrogate for cardiac
just
output?
lift the
And what are you going to see?
blood pressure.
an increase in like about this systolic 10 mm. Increase in
If you have an arterial line, you can go for it.
artery line, and then we look for at least a 10 mm rise in BP after raising the leg for about 1 to 2 minutes.
Okay.
Or we can give a mini fluid challenge, like we can give a 100 ml bolus and see the acute
You
dynamic.
will not find those things in guidelines and all. No? It's
Passive leg raising test, again, rather than lifting the patient's leg alone, we can
tilt the bed.
Tilt the belt.
That is what is a more recommendation.
The whole aim is by tilting the leg, we are expecting to improve the venous return and expecting an increase in volume of approximately 300 ml. Okay.
Most important thing, just go with the surveying sepsis campaign guidelines. What all things you need to do?
Urine output.
No, before that, you have to measure a lactate.
Or collect 3 send 3.
That's the basic thing that you have to do. I am not asking anything more than that. In a patient with suspected sepsis, you have to do these things. You have to measure a lactate. There is hypotension, you have to give fluids. And you have to start on a broad spectrum antibiotics after collecting a blood culture. So that is the thing that they are telling. The thing what we wanted. But always keep in mind that hypotension is not a unifactorial thing, it can be multifactorial. So in this patient, you have to see definitely what is the cardiogenic shock status also. There is cardiac status also might be affected. So we might need to start on an inotropic agent. So you have to be very specific. Noradrenaline is a vasopressor. Pure vasopressor. Dopamine is a vasopressor and can be an inotrope depending upon the dose. And dobutamine is definitely an inotropic agent, but it has got some vasopressor effect also. It can cause venodilation. So that can be happening in dobutamine. So dobutamine is an agent, classical example, which will increase the contractility of the heart.
Okay. At your level, probably we can discuss a bit more on fluids itself. So what's the current thought process in sepsis resuscitation? What is restrictive volume resuscitation in sepsis?
Restricted is
There are basically 2 schools of thought. One is actually we can liberally give fluids in the initial stage itself to like check for the response of the patient. The second will be like we have to restrict, or like we have to in the initial stage, so we preferably go start with an inotrope if the patient is not improving in the initial stage itself. So basically the idea is to like instead of pushing the patient to more like an ARD situation, we try to restrict the fluid from the initial stage itself. And because actually we feel even if you're giving fluids doesn't have any oxygen carrying capacity or anything to like improve the tissue hypoxia. So the new school of thought is to like restrict the fluids and start on early anatropes. case of sepsis like that.
Okay. So basically, there is a recent publication itself which shows that you give a restricted volume and the other arm remains a standard arm. So there has not been any worsening of mortality. It's almost equal. So now they're planning for more studies in this regard. And any role of albumin in fluid resuscitation?
Ideally,
Okay, albumin. The current thing is that if the patient has already received the volume challenge and there has not been much improvement, that will be a situation. Probably you can use albumin itself as a volume resuscitator. Okay.
One studies have even shown actually we can start both inotropes and fluid in the both limbs simultaneously also. New study.
Why balanced crystalloids?
One thing is actually if you're giving too much of normal saline, the patient can go into hyperchloremic metabolic
alkalosis.
Acidosis.
Hyperchloremic metabolic acidosis.
Oh.
And if you're pushing too much of RL, then patient can go into metabolic alkalosis also. So, better.
Whatever be the idea, balanced crystalloids, whatever be more physiological. They are trying to be more physiological. Balanced crystalloids they have come up with. See, one problem with when you treat DKA patient, you will initially see acidosis, but later on also there will be acidosis. What is the reason? Because of the fluid whatever you are given. So initially it will be a high anion gap. Now it has become a normal anion gap. So hyperchloremic metabolic acidosis is one thing that we need to consider. So that is the reason why they are bringing out to restrictive fluid therapy with balanced crystalloids. And again, if there is no hypotension, we wanted maybe a little bit of negative balance in patient. The patient is going into ARDS. As this may be an ARDS, we are not sure. We have to take an ABG, CPO2 by FiO2 ratio. Maybe an early ARDS could be also be the reason for this patient. Okay.
Okay. And regarding inotropes itself, like, do you really need a central line to start inotropes, or what will be how will be the way you will approach it?
Early resuscitation, definitely go with the peripheral line because if you want like immediately start, go for the peripheral line.
Peripheral line where?
18 gauge cannula in more proximal areas.
That's key thing.
Cubital.
Not something
cubital or
nearest and all. Yeah. So a good peripheral cannula,
maybe an EJV.
proximal or an EJV should be okay. But make sure that if the patient inotropic requirement is going up, so you have put a line, you have started on NORAD, post 2 hours you are seeing that NORAD is going up 10, again hypotension. So when the scenario within the first 6 hours, the trend is that the patient's inotropic requirement is going up, definitely that will be the time when you need to consider a central line. Okay.
So coming back to our primary survey, sir.
So what you did for airway breathing? She was having tachypnea, no? So what was done for that?
So sir,
36 breaths per minute.
36 breaths per minute.
Bilateral crepitations.
Yes, sir.
92% saturation. What you did?
So at this point in time, we counsel the patient and put a BiPAP on this patient initially itself. Because oxygen, considering her crepitations, we didn't know whether she was either in a fluid overload state or the crepitations were secondary to LRTI or it was because of ARDS. So on
Your
5
idea
liters.
is to improve the oxygenation here, right?
Yes, sir.
Your idea is to improve the oxygenation, decrease the work of breathing.
Yes, sir.
So what will be the ideal choice for this patient? That is my question. This patient has got hypotension. Hypotension, you are already 10 ml per noradrenaline going on. You want to put on BiPAP, which will again increase the intrathoracic pressure and will decrease the blood pressure. So what will be the ideal choice for this patient?
Even surviving sepsis campaign clearly says something over BiPAP, no, for hypoxic.
This is a type 1 respiratory failure. Maybe we are not sure.
If you are bringing in the cardiac failure component, then the balance tilts. But if it is purely hypoxemic failure following sepsis, septic shock, what?
High flow
Usually you can go for,
nasal. High flow nasal.
So maybe a high flow nasal
Nasal
cannula
cannula.
with whatever knowledge what we have got from the patient. We have not seen the ABG. We have not seen the cardiac status of this patient. But whatever high flow nasal cannula can be one of the first line management for this patient. So we can start with maybe 40 liters per minute depending upon the patient toleration. Only the problem is with the initiation. The cost is a little bit on the higher side. But if it is a pure type 1 failure and maybe an early ARDS, that will be an ideal choice for this patient. Maybe you can just give a very minimal CPAP only. It will not give a CPAP or an IPAP that we get in a BiPAP machine. So that will not be possible. It can just tolerate hypoxia only. The high flow nasal cannula will be an ideal option for this patient. Again, hypotension. We start BiPAP, but hypotension
Has
can
to be
further worsen
worsen.
with an NIV starting.
So for the airway and breathing part, we tackled it like that, and then circulation wise, heart rate was 102 beats per minute, and but it was regular in rhythm. And so, disability wise, she had a GCS of full score E4, V5, M6, and pupils were bilaterally and symmetrically reacting to light. Exposure wise, she was febrile with a temperature of 100.2 degree Fahrenheit and had a blood sugar levels of 204 milligram per deciliter. So, from our primary survey, we assessed that the patient had two major components that were deranged. One was the airway breathing issue, breathing wise. She had desaturation, increased work of breathing, tachypneic with usage of accessory muscles. So she had respiratory distress. And the second thing that we had to tackle was the circulation part, wherein she was on inotropic support, despite which she was
Vasopressor
hypotensive.
support.
Yeah. Not vasopressor support, and along with this, she was tachycardic and was febrile. So at this point in time, we made sure that the patient had two large bore IV cannulas. We placed paracetamol as our antipyretic to tackle with the blood with the body temperature. And then the next thing that we did was to check her fluid status.
But yes.
Yeah, primary agents, blood gas wise, she had high anion gap metabolic acidosis with a pH of 7.3. PCO2 was 35.5, PO2 was 63.2 despite 5 liters of oxygen, and bicarbonate was 17.6.
What is the expect PCO2?
To calculate.
17 into 1.5. That is 17 plus 8, you can go 25.
25 plus
So
1,
8.
33, 32, 31.
31. So maybe compensator, maybe little bit on the respiratory acidosis. Minimum respiratory acidosis also is there.
You
Then
told about the
lactate.
PO2, no? So anything you want to add along with the PO2 in this patient?
So a patient is hypoxic.
You have to tell the PO2 by FiO2 ratio.
5
Because the
liters
patient is on
5
5 liters
liters of
O2.
oxygen.
Okay. So that will be, how will you calculate?
28.
5, 3 is 15.
21 plus 15?
37.
37, yeah,
It's approximately 200, no?
200.
Roughly
That's a
around
high. 300. Yeah, that's actually high.
mild, moderate, severe. So
Moderate.
this will be mild.
Mild.
No? 200 to 300 is
300
mild.
It is mild.
200 to 300 is mild.
Mild ART, yes.
Then lactate was 3.5 so millimole per liter. And we also got parameters for creatinine, and that was 1.67. Then bedside ultrasound was done to check for the fluid.
What was the anion gap?
No, no, right.
Anion gap?
You told Hagma, right?
Yeah, it was
I
high
want to know the
anion.
anion gap.
It was
Can tell the sodium, we'll calculate
15.6. So.
15.6. So what was the next thing when you want to do when you say high anion gap metabolic acidosis?
We check for the delta.
Delta anion gap or
gap.
delta vega?
Delta
What
gap.
is the delta anion gap?
Change in the anion gap by bicarbonate.
You said 15.
15.6.
What is the bicarbonate?
18.7.
17, 15. Similarly, so delta by delta, it's almost 1. If it is 1, there is only one acidosis. If less than 1, there is associated metabolic
Metabolic
acidosis.
acidosis.
Above 1, there is associated
Alkaline.
normal anion gap metabolic acidosis. That is how you have to infer. You have to infer. While you have to do.
Okay, so
You can't just say it is high anion gap metabolic acidosis.
delta.
That is basic internal type.
Yeah, continue.
We took an ECG, sir. ECG showed sinus tachycardia, but had T-wave inversions in the inferior leads and V3 to V6. So, along with this, bedside echo showed RWMA with grade 2 diastolic dysfunction and moderate LV with ejection fraction of 35%. So, some component of cardiogenic shock could not be, we have to consider.
Okay.
So, along with this, moving on to our general physical examination, patient was obese. Along with this, but moderately nourished, and then respiratory wise, she had air entry to be bilaterally equal, and bilateral crepitations were heard more on the right side, predominantly on the posterior lung
Anything, any
face.
other positive findings?
And along with but there was no pedal edema, no raised JVP as such,
So what
and
does
dry
that
tongue.
indicate? There is no pedal edema, raised AVP. What does that indicate? But you are telling that RWMA is a cardiogenic. It can be some cardiogenic shock components.
So systolic heart failure is
What we can tell one thing is that right now the ejection fraction low may be secondary to the sepsis that could have worsened. She has got some RWMI, so it can be a sepsis related type 2 MI. We are not sure. It not be a primary cardiac event because of the sepsis. She has got some myocardial dysfunction also. That can be attributable to that. The patient is already in pediatric everything. There is an underlying failure on top of sepsis. It would have failed. That can be the inference. She was doing all right, right? Like 10 days back,
She was
itself she
fine.
was doing fine.
Plus she had dry tongue, dry oral mucosa cavity on it, and then but no pallor seen. And then moving on to the other systemic examination was unremarkable. Sample history wise, she was a known case of diabetes, hypertension, dyslipidemia, hypothyroidism, CAD history with previous anterior wall MI, and angiogram had showed single vessel disease.
For which study was done?
Medical management.
Medical.
That's about it. And then, so her current medications included Thyronorm 75 microgram, plus furosemide, triglyceride, nitrates, and then dual antiplatelets with statin.
Okay.
And OHA vildagliptin 50 mg that she was taking. Now, events that led were pretty much the same
Whatever we have
LRTI.
discussed. So now how will you proceed? So what will be your diagnosis? X-ray?
X-ray showed bilateral ground glassing opacities was there, sir. More in terms of pulmonary edema, with along with this right side lower zone, there was a consolidation.
Whether you will call it as pulmonary edema or you want to call it as ARDS. That will be my next question.
That is by ARDS by definition. We'll have to
Let me check.
For all practical purpose, it is non-cardiogenic pulmonary edema is called as ARDS.
ARDS.
So, X-ray wise, it's going to be a little tricky for you to diagnose. No?
She had a cardiac component also.
So management wise, there is no major change as such. You have to keep it. You have to remove the excess fluid. Give positive pressure ventilation. Whatever be the, it's going to be the same only. But what to call? Whether it is ARDS or pulmonary edema, that is the question here.
So in our initial management, we started it from the primary survey parallelly, wherein we made sure that the patient was the airway and breathing part was tackled with non-invasive ventilation with oxygenation to maintain a target of SpO2 of above 95%. And then our circulatory target was to keep a mean arterial pressure of more than 65 mmHg. And then
So how will you achieve that now for this patient? You said this patient is having hypotension, so fluid challenge is out. Fluid you cannot give because already there is reduced ejection fraction.
So, sir, in this patient, how we went about is we checked the bedside ultrasound for the IVC, and that was collapsible. And then, since the patient clinically also appeared dry, we did give a patient bolus challenge of about 500 ml.
Okay.
And then we checked for urine output hourly, and along with this,
Just response in BP will be the first thing, no?
so then
Was
the
there a
BP,
response in
the,
BP?
the BP picked up after our fluids, and then we hiked up the vasopressin agent from 8 ml. We titrated it, and then once the requirement went above 10 to 12, we added another inotropic agent, and that was vasopressin. Again, another vasopressor agent. With the dual supports, her BP picked up. So we did not push in more fluids, and now we gave her diuretics to tackle with that.
Okay. Suppose imagine her BP was 100 by 60.
So that again would be alarming, because if at all patient was previously hypertensive, then 160 would be
So what will you do
hypertension.
at that juncture? 100 by 60, same patient. BP is 100 by 60. The patient was on ongoing noradrenaline, and you've done your echo and you're saying that this
Moderate
is the dysfunction is there. So what will you do at this juncture? Do you want to do anything or just want to wait and watch? One thing is that if the patient, your other parameters like perfusion is not improving, you're not happy with the perfusion, maybe you can think in that term, maybe an inotropic agent, like may help. It is not just looking at one value to increase, but depending upon totally patient as a wholesome, you can think of it.
You're convinced with the cardiogenic component also.
Dobutamine wouldn't be our initial choice because initially it will cause the
It will
vasodilation.
not be during
So
hypertension.
once,
Definitely, it will not be the choice.
so
Once the
once
BP pickups above 90, you can definitely think of.
So the circulatory targets we had, and we checked for the fluid status, provided the patient with fluids, and then tapered not tapered. We added on the
Vasopressin.
supports. But following which, on reassessment, patient's body temperature had returned to normal. Tachycardia had settled. She was maintaining saturation on NIV with pressures of 12:6 and FiO2 oxygen of 4 liter. 3 to 4 liters she was on oxygen, and along with that, yeah, so
So
blood
you are
sugar
taking care
levels.
of A, B, C.
Yeah, that's
Then
done.
what else? Definitely manage it.
Then, according to the sepsis guidelines, within 1 hour we'll have to check for the patient's serum lactates and send for, it's a bundle, 1 hour, 3 hour, 6 hour bundle.
Okay.
So serum lactates and blood culture has to be sent for, and antibiotics have to be started within 3 hours of resuscitation. Fluids also have to be
Wait,
given
the
and
antibiotic
completed
timing? How soon you have to give the antibiotic?
Preferably
within
within
1
1
hour.
hour.
In?
1 hour.
So, in septic shock, if it is probable sepsis, up to 3 hours within a period of 3 hours.
So that 3 hours is to rule out other non-infectious causes. So if you're still keeping sepsis as a diagnosis, then you have to give within 3 hours.
Within 3 years. Then it has to be completed. 30 ml per hour fluids has to be gone, and then lactate clearance also has to be checked. The serum lactates and then urine output for monitoring of fluid response
Now,
and
what
the
is
patient's
lactate clearance?
overall.
When are you going to relook it?
Within 2 hours. 2 hours we will check, wherein we will take the difference of the patient's present lactate and the past lactate, and then multiply it by patient's initial lactate and
Okay, fine. What does
multiplied by
Idea
100
is what has happened to the lactate.
lactate.
we are expecting at
Into
least
100.
20% reduction in 2 hours. Will be a reasonable kind of.
100, no?
Okay.
So
So-
we'll check for the lactate clearance, and then IV antibiotics.
Krishna asked about definitive management. So this patient, what is the definitive management here? The problem is sepsis, right? So
Antibiotics.
yeah, what is the
IV
choice of antibiotics? Choice of
So,
antibiotics.
we will.
How will you
since,
choose?
Again, a gram positive, negative, and then patient had a hospital admission, so we'll be even covering up the hospital acquired infections too.
Patient was in the home. Initially, they started with azithromycin. She didn't improve. She got admitted to the hospital. So, got admitted to the hospital. And what was the status for those 5 days? She improved initially and then later
So
deteriorated.
there we did not have much of data, but from whatever data that was available, it was a reference letter which did not tell the patient's progress story, but a patient's current state from what when they were writing the letter.
Okay.
Patient was BP was not recordable.
Okay, so she went into a shock.
Yeah.
So suppose the treatment was okay, she will not have responded, or maybe initially it was okay, and after 2 to 3 days she worsened. So what could be the reason? Then hospital acquired infection.
Hospital-acquired
We have to
infection.
think of all those aspects. So we don't know exactly. So she has come after 5 days from an hospital. So definitely hospital acquired infection will be one of her differential. Maybe an underlying she had a minor viral infection. She went to the hospital, got admitted, got an probably
bacterial.
secondary gram-negative bacterial infection, and she came in with shock to you. Or maybe the primary presentation itself will have been a gram-negative infection. We don't know because already she is diabetic, everything. So whether that coverage was given adequately, we are not having that history.
Yes.
So what will be the antibiotic that you need to choose in here?
Sir, an empiric therapy at this point in time, because it is not organism targeted, so an empiric coverage will be to cover an antibiotic that covers both gram positive, negative, and
No, at this point we are talking about hospital acquired infection. So you should be a little more specific.
Pseudomonas
Like
and
are we talking about MDR bugs, MRSA bugs? So you have to be talking in terms of resistance patterns. Okay. So definitely we'll need an MDR cover here. I'm not too much bothered about MRSA. In our part of the world, for pneumonia to be caused by MRSA is not something which we commonly see. So I'd be happy with an antibiotic which is giving a reasonable MDR cover. Okay. In situations where there is extensive carbapenem-based resistance, so we have crabs and CREs and all, then probably you have to go beyond carbapenem. But here, immunocompetent patient, otherwise not much of comorbidities, not reasonably doing well, not multiple hospital administration, no previous history of receiving carbapenems and all. I still believe that at this point, carbapenem is a reasonable choice to start with. Okay, but we should wait within 48 hours. If the patient is not improving, then definitely we might need to consider otherwise. Okay, and then carbapenem and what else?
imipenems, carbapenems,
Imipenem is carbapenem.
Plus the macrolide.
macro.
And also, if you're suspecting any
Macrolide she have already received for 5 days.
this okay.
That's it. So only one coverage would be enough.
Carbapenem.
Because that will also have a pseudomonas coverage
Yeah, it will
and
be
a multi-drug.
Except carbapenem will cover except.
Atypical also will cover anaerobes.
Anaerobes will cover. A typical will be something
That, but she has already received azithromycin. So 5 days if she has taken, that will be there for another 10 days. So what else? MRSA do not cover. MRSA do not cover. That's usual. Then drug resistant to that and antifungals.
Then antifungal.
That will be the only thing that antifungal effect is not there. So that is the only thing that you need to consider. But here HbA1c some 13, 14, and she has been receiving carbapenem for already 5 days in the hospital, and she is coming to you. So maybe procal is not elevated. So at that time you might think of a fungal sepsis also. But right now we are not suspecting. But maybe after that, maybe you're in hospital immunocompromised for a long time, and then you have to think of a fungal sepsis also.
Then definitely, if the patient is not improving in say 24 to 48 hours, then you will need to consider adding dual gram-negative coverage. So that will be either with one of the polymyxin groups, colistin or polymyxin, or minocycline, phosphomycin IV, those things like that. Okay.
How is the patient now?
Patient has ever since her lactate clearance came down to next lactate was about 1.7. So through a course of stay, she has improved. So we are now starting her on BiPAP spacing. And urine output initially when she came in here it was 20-25 ml per hour, so which has improved now to 100 ml to 150 ml per hour. We are maintaining a slightly negative balance considering the patient's respiratory status. And we started the patient on dual antiplatelets because she had serially increasing cardiac enzymes. So perhaps that could have been an ACS event which is triggered by sepsis, or it could have been a stress cardiomyopathy. So, and her NT-proBNP was 43,000. Procal was 33, but all her infective parameters has been it's downtrending. Yeah.
Any role for esmolol in sepsis or septic shock?
Esmolol. Esmolol again, beta blocker, short acting. Patient in shock.
So especially once you see all these septic shock patients, we will be giving a lot of inotropes and all, and there will be specific tachycardia 130s, 140s and all. So those group of patients, a small dose of esmolol has been proven to be beneficial by keeping the heart rate reasonably under control. So we target usually the recommended doses 0.05 mg per kg per hour, not exceeding 25 mg per hour. Okay, and there are multiple studies which has advised to keep the target heart rate less than 100. Okay, because again increased heart rate is going to derail the whole thing. No.
Minimum dose.
Anything else?
This patient will also be titrated the insulin doses.
That's exactly. So, what will be the threshold to start in? What is the mode of insulin recommended in septic shock?
Basically, she had some mild AK also, so we actually prefer short acting like simple like
No, infusion, bolus. What is it?
we can either go for intermittent boluses.
Septic shock on inotropes always go with infusion. Go with infusion. Okay. If the target sugars are not falling below 180, go with infusion for septic shock patients.
We prefer to maintain like between 80 to 120 range.
80 to 120. It's 140 to 180. 140 to 180.
Okay. Then actually if the patient is actually prolonged bedridden, we can even start about DVT prophylaxis and also keep the patient in a prone position, then monitor continuous fluid output and all that, urine output. Then suppose the patient is going into ventilation, we have to think about like ARDS ventilation, like 6 ml per kg tidal volume and all that. And again, if the FA to PA to FA ratio is again going below 150 and all that, we can even think about prone position from the second day and all that.
Okay, I don't think we'll go that route.
This patient, nothing.
Another 1 hour. There'll be earlier discussion. We'll do that.
So basically, this patient initially we started around IV antibiotics, meropenem, and along with that, this thing, antiviral fluid also we started. Fluid resuscitation which we improved. We started on initially Norodan vaso, but slowly we tapered vasos. Now she's only on minimal dose noradrenaline. Her lactate has improved from 3 to about 1.2, and she has hemodynamics and sensoryals also improved. Okay. She's off BiPAP. She's doing it.
What's the role of midodrine in septic shock?
Midodrine actually, if you're like she's going in a very low dose and all for a long time, we can start midodrine to taper this thing.
Taper the vasopressor.
Taper the vasopressor like that.
Okay. So, in a nutshell, what is the message?
That early recognition of sepsis can prevent complications
Early recognition,
and intervention.
intervention. That is the key. Early recognition and intervention is the key. Our primary thing is airway, breathing, circulation. You take care of that. Rest everything will be all right. So you identify, start antibiotics, send a lactate, see how it's improving. If lactate is not improving, you have to think, okay, some pathway is wrong. I have missed something. So that is the role of each thing. Suppose till this patient lactate is 5 or 6. We are not targeted that issue. Something we are going wrong.
Saying, for completion's sake, what's the role of procalcitonin?
So procal just stands for bacterial, for the etiology of it. If a patient has elevated procal, then the good chance that the sepsis is
No,
caused by bacterial
what's the
sepsis.
utility of procal in management?
Prognostic.
There is no, you cannot be starting the antibiotic based on procal. Never do that. Okay. The role of procal is limited to de-escalation. Okay, if you have a patient who has a procal of 100 and in follow-up you are seeing a reduction in procal, that says that your antibiotic is working. Okay, so never base, because the procal is low, I won't start antibiotic. Never take that decision.
Procal is high, I want to give meropenem. That is also wrong.
Okay, fine.
Okay. Thank you.
Sir, thank you.